So in part two of the videos for this week, I'm gonna scroll through both this New England Journal of Medicine article that looks at two types of treatment for individuals in septic shock, and then I'll go over the second example that covers this kind of reminder protocol for vaccinations, right? One is quantitative, one is qualitative. They differ in their findings, but I want to give you an overview. So in this article, the first thing I definitely look at is the title, right? So what is it inferring? It's looking at two treatments, so or two ways of differentiating groups, those with high versus low blood pressure, and the relationship to septic shock. You'll see there are many people publishing, right? We tend to kind of chuckle and say, like, who's really doing the work here, right? And it's something we consider an authorship. You'll notice that, sorry, forgive my scrolling, there we go. And that you'll see that this abstract is structured, right? It has the heading. So they're looking at a campaign to survive sepsis, and they're targeting pressure during resuscitation during septic shock. So they're actually doing it with two different groups, and they don't know if more pressure is actually better. It's a multi-center trial. That's where there's so many people, with random assignment of 776 patients with septic shock to undergo one of these treatments. Sorry. We know that, and every time you see anything that is highlighted in yellow, these are answers to your demonstration. So I want you to go through with it, see if you can find where these answers are, and then go back and match it up, right? So this would be an answer for question 6. They looked at the differences in 28 days, given both these treatments, the high target and then the low target. And what did they find? There was no statistically significant difference in mortality at 90 days. Interesting, right? So they did a study with very limited results. Their conclusions were that targeting this pressure compared to a lower pressure did not result in differences in mortality. And we see here that this was funded by the French Ministry of Health, and it did have a clinical trials number. So it went through an ethics board, and it was funded. The first thing we see is the background here. This is all of the context or the introduction. So why are we studying septic shock? Why is it of interest? Sorry, let me adjust this a bit. Let's do, okay, that's probably a little better. My computer decides to be wonky. Come on, computer. So this is all of the justification as to why this study is important. People are not living with septic shock. We have this idea that maybe higher pressures would be better in the introduction here, but does it really work? Here's the study design and all your methods. So when did they enroll people? Where did they enroll people? How did they enroll people? What mechanism was used to select individuals, patients, participants, subjects for the trial, right? Randomization was used in a blinded fashion where patients did not know which group they were assigned to. Also, members of the safety and writing committees and staff did not know the assignments. Sorry, I'm sorry, this keeps jumping. Computer. This section here gives a description of who are the study patients, right? What is the study group? And it talks about the thing we mentioned, who are they excluding? Exclusion criteria were legal protection, those without a guardian, those with no healthcare affiliation. And are there differences in those that have affiliation with healthcare and those that don't? Those in other studies, etc. And here again, they talk about the two groups. The study treatment is described in detail, the fluid resuscitation, what was in the resuscitation mechanism, what was the pressure in the high and low target group, and then what were the outcomes. And let's think about this, that they looked at 28 days and 90 days, and they're not finding much difference. What analyses did they do? We'll talk about power analyses later, but you have to figure out how many people are important. So they're saying they did calculation to figure out how many people to include in the study. They did not replace people if people dropped out or they died. And then, read through, they talked about regression. We'll talk about regression later, but at least they're defining in good detail how they statistically analyzed these two groups. And then again, they restated in the results how many people and how long they followed them. If you like a visual depiction, this is really powerful, right? They began with almost over 4,000 patients, and then these are all the exclusions. So, you name it, all of these exclusions eliminated many, many thousands of patients. They began with from 4,000 to 800. And then 2 people signed consent but were not randomized. So they ended up with 798 people from over 4,000. So you need to think, are those people that were the final study participants, do they differ from those 3,000 plus people who we excluded? And here they're talking about results and outcome. Right, this is a descriptive statistics table. It talks about the differences or the characteristics in each group. So both were kind of similar in age. They looked at the number of men in each group, or males, I'm sorry. They looked at different scoring, organ failure assessment. They tried to look and say, well, these are kind of similar, but not in some ways. Look at the surgery in the low versus high target. The pre-existing conditions, they kind of synced up. In some ways, there's differences like COPD. So you want to look and say, like, maybe some of the findings they found are because the way they assigned the groups made the groups very different, with one, having more or less of some conditions than another. Right here, it's pretty similar, although it looks like more people had other sources of infection in this second group. Right. This is hemodynamic and biochemical. So their heart rates, their arterial pH, all this kind of stuff. The fluid therapy, similar-ish. Right. What medication they were given. Right. Similar, but a little bit of difference. We need to really think, are these statistically significant? And we don't know. If they don't provide it, we can't do it. Right, so we get a sense of, is each group that they assign similar or different? And then the discussion. Right, don't be fooled by fancy tables. They're tracking pressure within each of the groups. And then they're talking about outcomes. Here, when you see these are p-values, so less than 0.05 is the minimum that we can get for statistically significant outcomes. So these are all not significant. These are all significant. But they're looking at a lot of their outcomes, like differences in death or survival is not significant. But chronic hypertension is. Renal replacement therapy just barely made it. So their main interest of prolonging life or decreasing death from septic shock using pressure did not work. And they define it. They did not, and these are their references. But they did not. They included their affiliation, but they didn't include who did what portion of the work. Right, so we see this as a quick overview of all the aspects of the study. If you wish to find any of the answers to any of the questions in the study, I listed them all here, right? Any single highlighted piece should match up to where you found the information. And I'm going to screen share again. So we went from a quantitative article where we did some regression testing to look at how two treatments that were being tested to see if they prolonged life or decreased, prolonged life with septic shock or patients in septic shock. Now we're looking at these recall or reminders for immunizations, right? So the systems that ping you and let you know that you require, think of my chart, or think of if you register for any vaccine, you'll get a text or you'll get an email that's a reminder from the company saying, hey, you have an appointment on Saturday, September 15th, or whatever it is, right? So this article is a qualitative article. And if you look at this abstract, this is a non-structured, right? Everything is written as a paragraph. It has many authors, but much less than were present in the prior study. And all of the information is here, right? This recall system is an evidence-based strategy for increasing completion rates of vaccination, right? Giving a notification works, but they found there's some barriers. What are the barriers? And then what are the incentives for people and health systems to use these reminders? They spoke with leadership, so they spoke with individuals in hospitals and other administrative positions to see what their take was. And how they got this reminder system instituted within a facility or an institution. And to get providers to actually use it. So they talk to key stakeholders. If you read here where it says several considerations were determined, this reads qualitative, right? We're not talking about statistical testing. We're talking about understanding or getting deep knowledge about this concept. You'll notice the same process. They begin with an introduction. So what's the deal, right? Why are we studying it? We're studying the system of evidence-based strategy for increasing vaccination, but we know that it's costly and we know there are some problems in getting it implemented. And it's not really been researched. So we want to research this problem. And I'll show you what's a little bit interesting, here. If you look at their method, they talk about stakeholder interviews. And stakeholder interviews are important because unless you're somebody in that situation, you won't have knowledge about the topic. And they provided justification of that. And they also met with review boards. They did give them an incentive, right? So a lot of times I personally like to do it if I have any sort of compensation for people because time is money. So people in that study were paid $50 to $100 and they're saying they had to pay more. We usually pay 25 or 50 because they were physicians and executives. And they snowball sampled, which means if they interviewed an executive or a physician at a hospital, they'd say, can you recommend somebody else who might also know about this reminder system? Their data collection was semi-structured interviews conducted by phone, right? So think about that. What is the utility of calling people by phone? Why not do it virtually? Why not do it via Zoom or Skype or WhatsApp? Like, why choose that that method. They audio recorded and they transcribed their data. Data analysis. So in the other article, if you looked at our data analysis, it was regression comparing that high and low pressure group, right? With the septic shock, like survival as the outcome. Here, the team conducted a textual data analysis. So they coded, they transcribed, typed out everything that everyone said on the telephone, and then they looked at themes, or they looked at what they saw as commonalities and differences in what these stakeholders were saying. Each coder coded it, so each member of the team coded separately, and they would add codes if one came up with a new code. If they had any difference, they would meet together, and they're saying 20% of the sample, the individuals or the transcripts, the interviews were coded by both coders to see if they were consistent. So if you and I are coding an article and I say this theme means that, you know, the problem is that my administration doesn't give me the software to do this, and you code it and say it's all about financing or it's about employee conflict, we can't code the same information differently. We have to code the same information the same way. So we need to kind of, or what they're showing you is we need to get 20 cases and code them separately and compare them, and to see if we're kind of in the same mind frame or in the same way of thinking about coding. If you look at their results, they had 24 organizations and they had 23 individuals completed an interview. So they're looking at 23 people. They're not looking at a larger sample like in septic shock, because in septic shock, they want to look at an overall finding of a health outcome. Here, they want to look at a deeper understanding of what are the barriers about getting these systems in place at a hospital. These are the themes, right? They're talking about what is the system itself. And they talk a lot about the funding source. So CDC was given the most times and talked about as being helpful or not helpful in supporting the cost that it takes to get these systems instituted at a hospital. And here's a visual example of all of the issues or all of the themes that came out, right? Decision-making, who makes that decision? Stakeholder buy-in. If we put these systems in use in the hospital, will people use them? There might be like data and technology issues of HIPAA or managing it. That external funding of CDC, partnerships, right? How do we get all of our partners to also buy in and use this electronic system? And then how do we evaluate if it works? And what's interesting is, like, what do we say in the message, right? You know, please remember to bring your health insurance and come to your, you know, your COVID booster, you know, on September 17th, or what do we say? So these were all of the issues that came up when the researchers were listening and recording and transcribing what the stakeholders or those people were saying. Right. Each theme is expanded upon. In the discussion, you'll see that they talked about going back to the literature. Here's what we knew. We knew there were barriers to implementing these systems, and we knew there are a lot of benefits, but here's some things that we found, right? Lack of funding, poor contact data, right? We can't access patients properly, and that costs may be deferred. So initially it's a high cost, but it may be lower. And that sometimes these messages are unclear, that you're pinging people with messages, but they're not quite sure, like, do I need this vaccination? Is this just an automatic text I'm getting, or an automatic message in like my chart, this kind of thing. They also talked about some new things. What are some new ideas? Right, that both patients and providers like these systems, which is great. And that if they're well received, they're going to continue, right? They're going to continue in use. So these are some things they found. What we also have to talk about, and this is the limitations, and we'll talk about this a little bit, but their strengths and limitations. And the first thing is that they really understood, and they had a high response rate amongst the smaller group they talked to. And they looked at many different kinds of groups, different kind of stakeholders, but this is counterintuitive. They should note that the results are not generalizable, but generalizability is not a goal of qualitative research. So within their research, they have rigor, they have, there's quality within the research, and they've got a wide range of perspectives, but that they don't want to broadly say that this fits all external groups or hospitals or people that are using these systems. So what they might say is future steps. They might say that, we need to explore the barriers and the strengths of using these reminder systems with larger groups of individuals, or multiple studies should be conducted. So we want to be aware that there are next steps. Here they talk about no known financial competing interest or conflict of interest. If any of these authors were employed by the hospitals that they're researching, they would need to state it, because there might be some conflict of interest there. And then we look at the references, because if we're really interested in the topic, these are some really good references to read up on. And what's nice in this article is that all these people discussed what they did, right? Think of group work. We all work in groups, and sometimes we feel like someone carries the group or somebody's slacking or whatever that is. But peer-reviewed articles are doing the same thing. So they want to know which article did what, which author contributed what, so that it's not really one author doing everything and everybody else kind of tagging along, or it's not it's equitable distribution of work. So here we know exactly what people did, who created the study, who contributed to the design, who conducted the interviews, and they're different people, right? So is it okay that somebody different conducted the interview than analyzed the data? So it's good to know. Let's just look at funding 1 second, sorry. And it was supported by an NIH award, which are federal awards that are not hospital-based. So here they are. Let's see. No competing interest. So that's fine. NIH awards are federal awards, and they're not based in a health system, and NIH does not influence anyone's research. So if you want to take a little time on your own, look and see if you can answer the questions. Every single question for each article is listed here. I've highlighted the sections where I found the information. The great part about articles is you can probably find that information many places. It's redundant, which is great. And so give yourself a little, wiggle room, go through the articles, try to answer the questions in the demonstration document. And then if you want to have the results, they're all posted here. Here's where you can find the information, right? Right, this is question 15, limitations and strengths too. So hang tight, I'm gonna create one more video and show you, if I have 3 journals that are publishing a study about a topic, how can I assess which journal might be, better read, have a better impact, have more cited authors? We'll look at that next. So see you in a few.